Hi, this is Dr. Jonathan D. Hall coming to you from the North Shore of Boston with a Thoughtful Patient's Guide to Plastic Surgery. Today I'd like to talk about proven techniques to improve your recovery after breast augmentation. Jessica has been my medical assistant for the last 2 years, and she said to me, why don't you talk about the way that you do breast augmentation, because patients coming in are really having a lot less pain and feeling pretty good after a day or two, and she's talked to her friends that have had surgery, and some of them are still having pain for 6 weeks or more. Today I'd like to talk about some of the techniques that I found to be helpful over the last 25 years. So after finishing medical school at Washington University in St. Louis, I did my general surgery and plastic surgery training at University of Michigan. And one of my mentors was Dr. Reed Dingman. And Dr. Dingman was a very famous plastic surgeon, was brilliant, and taught us to do many things. But one of the things that stuck with me the most was his approach to patients in plastic surgery. And he would come to speak with us at the end of a day. He'd come into the residence room and he'd say, boys, if you're still doing it the same way I taught you in 25 years, I'll be disappointed. Meaning continue to learn new ideas and discover ways to help our patients. And I kind of shiver thinking about that, because it actually now is about 25 years later, and I like to hope that Dr. Dingman would be proud of his residents and how we're taking care of patients, although we're not doing things exactly the way he taught us. So, breast augmentation. So by the time we get to the breast augmentation and are actually in the operating room, we've already made a lot of decisions. We've decided, are we going to go above or below the muscle? Are we going to use a rounder shaped implant? Are we going to use a textured or a smooth implant? Are we going to use saline or silicone? We've really, the surgery itself is making the proper space. So we're making a space which is, in 95% of the cases, we're going underneath the muscle. So we'll talk about that today, but we're making a space for the implant. We want to make that space as precisely as we can, with as little trauma as we can. So we were taught to do blunt dissection for breast augmentation. So blunt dissection basically means we go in with a finger or with an instrument and basically go through and tear the tissues where the implant's supposed to go. In fact, the Dingman dissector was developed by Dr. Dingman, and it's still used today. In fact, I went to a national talk last year, and one of the plastic surgeons was given a national presentation on doing breast augmentation, was still showing blunt dissection and still using a Dingman dissector. One of the doctors that I follow a lot with his thoughts and ideas is Dr. John Tebbetts, who is a plastic surgeon from Dallas, Texas. And Dr. Tebbetts in 2002 published an article in the Plastic and Reconstructive Surgery Journal about using refined techniques to give patients a 24-hour recovery after breast augmentation. And doctors were astounded, and I was astounded, and a lot of people didn't believe it, and a lot of people actually still don't really believe it today. But I met with Dr. Tebbetts at several of our national meetings, and he was kind enough to speak with me, and he corresponded with me, and I obtained some of his videos studying his technique, and was able to obtain many of the instruments that he uses, and now I have a set of the Tebbetts, actually several sets of the Tebbetts instrumentation that I now use in the operating room. So I've been using his techniques now and really liking them for the last 13 to 14 years. So he did a follow-up article in 2006 comparing his technique to the standard blunt technique, and again showing that his technique led to a reliable recovery for many patients in 24 hours. And interestingly, even as late as 2013, there were still doctors fighting about this in the journal. And one doctor actually wrote that he kind of didn't believe that Dr. Tebbetts could have a 24-hour return to surgery, and Dr. Tebbetts actually wrote a letter back, and since that time the other doctors' comments have been formally retracted by the journal because Dr. Tebbetts could prove that his technique works. So what is this technique? How is it different? Well, he had really 6 parts of the technique. And the first part was to use prospective hemostasis. So what is prospective hemostasis? Well, normally with surgery, we'll go in and we'll cut some tissue or with blunt dissection tear the tissue, and then when we find a blood vessel that's bleeding, we'll cauterize it. And Dr. Tebbetts says, why don't we go in very carefully and try to see that blood vessel before we tear through it and cauterize it. So the Tebbetts monopolar forceps are insulated forceps, and when we squeeze the end together, an electrical current goes between the ends and will cauterize a blood vessel, so electrosurgery. And so if we can go in through surgery, I like doing it this way, and if we're fortunate, it doesn't always work exactly as we'd like, but if we're fortunate, we'll maybe only lose less than a teaspoon of blood, and we very carefully make this the pocket for the implant. And so the other idea that he called it a no-touch technique, which again kind of makes sense, just being very gentle. And he said, if you're in with a blunt dissector and you're banging against the rib cartilage and banging against the ribs, which is the periosteum and the perichondrium respectively, that there's more pain, which kind of makes sense. And so we use the special lighted instruments and we lift up the tissues and very carefully make that space with the monopolar hand switch cautery forceps. And so there is no more blunt dissection. And so I found that early on I would make the space temporarily for a breast sizer, that we make a temporary implant to kind of see about where the space is supposed to be, and then gradually enlarge the space. So in other words, I start with a smaller space and then put in a temporary implant, and then I go in and finish making that space. I found that if I'm tempted to do just a little blunt dissection, that's always the spot that hurts. So now all dissection is performed under direct vision. So I go back in with the lighter retractors as we were taught by Dr. Tebbetts. Again, not my idea. Dr. Tebbetts taught us how to do this, and very carefully make that pocket with the cautery dissection. So the special instruments are helpful, and the other thing that he found to be quite helpful and showed in his article was to use muscle relaxation during the surgery. So what does that mean? Well, I do the surgery under general anesthesia at the hospital, and the anesthesiologist gives a medication that relaxes the muscles during surgery. And so this prevents the muscles from contracting or spasming or twitching during the dissection. So again, less trauma and an easier recovery. So a 24-hour recovery. So what does that mean? Well, I tell my patients that if I have 100 women that I do breast augmentation on, one woman will say, I had quite a bit of pain, I needed to take the Percocet and the Advil for a week. And 20 patients will say, I felt like going out to dinner, all I took was the Advil. And 79 patients, or 79 out of 100, will say, what, I needed the Percocet and the Advil for a day or two, and then I just took the Advil. So I will say that kind of goes along with Dr. Tebbetts, that a large number of the patients by 24 to at least 48 hours are feeling fairly recovered. Now, where I'll disagree politely with Dr. Tebbetts is that I don't think that patients should be out doing their normal activities right after surgery, because even though you feel better and feel pretty good after 24 to 48 hours, your tissues are not healed yet. So when we cut and repair tissues, the tissues get actually weaker for the first 3 weeks. So that 3 weeks after surgery, the tissues are actually weaker than when they were repaired. And then gradually between the 3rd and the 6th week, the tissues start to regain their strength. So that's where the 6 weeks of being careful comes from. So I'll have most patients are feeling pretty good after a couple of days, and they're back to office work after a week. If I have some of my nurses that have to be able to lift people up in beds, they might need to take 6 weeks off, or just avoid doing any lifting for the 6 weeks until their tissues are healed. Also, if you were to strain in the first few weeks, it would be more likely to have a blood vessel that could open up and you could get a hematoma. Again, very uncommon. I've had one patient in 25 years who was lifting a 20-pound baby 10 days after surgery and got a hematoma, but usually if you're careful, that doesn't happen. So again, I think 24 hours, most patients are feeling pretty good. 24 to 48 hours, just taking Advil, and but still 6 weeks of being careful. Again, this is Dr. Jonathan D. Hall coming to you from the North Shore of Boston with the Thoughtful Patient's Guide to Plastic Surgery. Today I've reviewed the proven techniques that I use to give my patients a predictable 24-hour recovery after breast augmentation. They include perspective hemostasis techniques, no-touch technique for the periosteum and perichondrium, eliminating all blunt dissection. We perform all dissection under direct vision, modified instrumentation, and optimal use of muscle relaxants during subpectoral dissection. Thanks for listening to us today, and please be sure to send along any comments or any topics you'd like me to discuss on the next Thoughtful Patient's Guide to Plastic Surgery.